I would like to welcome our esteemed faculties and all the participating doctors for a wonderful webinar on centered around the discussion of in-depth HBR study, which we have published recently, which have covered some of the important aspect and the real world insights from the Indian intervention cardiologist on managing the high bleeding risk patients. But before getting into the detail, I would like to call our AGM marketing, Mr. Anand Chitre, to take us through a brief corporate presentation. Over to you,
Yeah,
Anand.
thank you so much, Vaishali. I welcome all the delegates and the faculties for today evening's webinar revolving around in-depth HBR, need of de-escalation in Indian context pertaining to the high bleeding risk patient, and also, of course, talk about the unguided de-escalation. So I think this is a topic of interest, and I think a lot of discussion is on and around happening in international bodies as well. Let us have our Indian perspective, and to talk about that, we have esteemed faculties have already joined the chat box. The speaker faculty have joined the speaker box. Sorry, we have Dr. J.C. Mohan sir with us, Dr. Abraham Mohan sir, and of course with Dr. V.T. Shah sir from Mumbai. So I'm hoping for an excellent discussion post the slide presentation.
So as already mentioned, that today's discussion is on a very interesting survey finding, the second edition of the in-depth survey, which we have already conducted a year back. And this is the extension of the in-depth survey where we come out with many more new findings, that is in-depth HBR, which is going to highlight and capture real-world insight from Indian intervention cardiologists on managing high bleeding risk patient post-PCI. So this study was carefully curated and the surveys were designed and held not by our course directors, especially the eminent panelists who are joining us today to give us more insight on the study. So we have with us Dr. Professor J.C. Mohan sir, who is chairman and HOD at Jaipur Golden Hospital, Delhi. I again welcome you, sir, for today's webinar and also for the wonderful insight throughout the journey of in-depth HBR consensus report development.
Thank you.
Thank you, sir. We also have with us Dr. V.T. Shah, sir, who is associated with the Shah Diagnostic Center and Clinic, Mumbai. He is going to join in short while. And we also have with us Dr. Abraham Oman, sir, who is a senior consultant cardiologist at Apollo Hospital, Chennai. Thank you, sir, and again welcome for giving us the valuable insights and finding from the in-depth HBR consensus report. So before getting into the detail of in-depth HBR, we are very happy to share that already we have learned a lot from our previously presented study, a published study, that is in-depth study. In-depth was our first consensus report on de-escalation from DAPT to SAPT, which gives us an Indian perspective for bleeding risk in ACS patients. The study we have concluded with 210 intervention cardiologists across India, where they have shared the experience about the de-escalation part. And the study indicated some of the major findings. Like 1/3 of the respondents in the study, they feel that clopidogrel is the most suited agent when it comes to SAPT. When it comes to combination, they are mostly going ahead with the atorvastatin and clopidogrel combination, predominantly most preferred for management of CAT. Apart from that, the study also highlighted some of the need for India-specific guidelines on de-escalation from DAPT to SET. The study we have published in JAPI, one of the reputed journals. The main purpose or the objective of doing in-depth study was to define a timeline for Indian subset of patient. What is the perfect de-escalation timeline? Where we have learned that especially the patient who are high-risk patient, HBR patient, there the duration should be less than 3 months, whereas for the medium bleeding risk patient, it is less than 6 months. Going ahead, then we developed and come up this year, which we have published, is in-depth HBR study. We have published in the reputed Curious Journal, which is part of Springer Nature. The purpose or the objective, why we did in-depth HBR. So basically, there is no standardized approach for bleeding risk assessment when it comes to HBR post PCI. And this study was aimed to gather insight from Indian intervention cardiologists who are primary decision makers for peri as well as the post PCI depth duration. And they routinely manage this kind of high risk patient. So, how they will evaluate the bleeding risk factors, there is a need for a simple assessment tools. And also, there is a practical strategies for optimizing depth therapy in HBR patient post PCI. So coming to this, some of the details we must be aware of, but from the study, what we got to know is that up to 20 to 40% of the patient undergoing PCI have characteristic of high bleeding risk. Bleeding complications are not only common, but are strongly associated with the increased mortality also, making it and it's an essential to clearly define and appropriately manage the HBR patient, which is certainly a little bit lacking when it comes to Indian context. Objective, I have already defined. So this is again a CAP survey where we have very carefully curated the opinion, the knowledge, attitude, and practice from intervention cardiologist. Coming to the methodology, the study was conducted across India with responses from around 400 intervention cardiologists. The study was structured and we have given pre-validated questionnaire which was used to gather data on the perceived prevalence of HBR in routine practice, key HBR factors which are specific to Indian patients such as frailty, comorbidity, and tropical diseases, preferred SAPT agents after depth, perceived bleeding risk profile of antiplatelet agents, and any barrier to implementation of de-escalation. And the data were analyzed using descriptive strategies and cross tabulation to identify the national and the regional trends, which I'm going to show in my upcoming slides. Coming to the demographic details, so total number of responses that we have received were around 375, and equal representation from all the zones were there. So basically, this is a pan-India perspective which we have gathered. Some of the key findings, so this is the regional and demographic details of the zone participation from the various zones. So we have representation from across India. Some of the interesting highlights and summary from the study. The survey revealed that in Indian practice, the burden of HBR post-PCI is estimated to be less than 20% of patient. And when it comes to type of bleeding, so GI bleeding is the most commonly observed, followed by subcutaneous, intracranial, and genitourinary tract bleeds. And also to the interest that two-thirds of the cardiologists they express the need for a very simplified bleeding risk score which should be tailored for Indian patient, because we all have seen that there are a lot of scores which are available, but some of them are very much difficult when it comes to simulate it in the Indian setup. Coming to another very interesting finding where our uh, panelists have helped us in developing some of the criterias for bleeding risk based in the Indian context. So some of the criterias they have put it as a very high importance factor. Some of them like 70 to 80% they feel that they are of high importance, moderate importance, and low importance. These are the four strata where it has been divided. So some of them are like hemoglobin value of less than 11 gram per deciliter, platelet count of less than 100, age more than 70, they were all put under high importance. So these parameters were commonly perceived as threshold beyond which bleeding risk become very much clinically prominent and significant. Coming to antiplatelet preference post PCI. So when choosing antiplatelet agent following short or ultra short depth, Indian cardiologists showed a clear preference order over here. Clopidogrel was the most preferred, followed by aspirin, ticagrelor, and prasugrel. Even in terms of dosage, clopidogrel 75 mg remains the top choice, followed by aspirin 75 mg, while higher doses or potent agents like ticagrelor and prasugrel were reserved for specific cases due to safety and bleeding concerns. Moving ahead towards cardiologists' preference for P2Y12 inhibitors and the bleeding risk perceptions. So, when ranking agents based on bleeding tendency, clopidogrel was perceived as having the lowest bleeding risk by about 48% of respondent, while prasugrel was rated the highest risk agent by 28% of cardiologists. With this data demonstrated that a practical tendency among Indian interventionists to de-escalate or prefer a safer P2Y12 option in HBR cases. Coming to another very interesting insight, which during the discussion with our esteemed panelists we come up with, is that as compared to Western countries, India is very different in terms of having a burden, huge burden of tropical diseases. So this is India's specific insight was the role of tropical diseases like dengue, malaria, and leishmaniasis, which can cause thrombocytopenia, a very common feature of this tropical disease characterized by significantly reduced platelet counts, sometimes as low as 5,000, and may be accompanied by a packed cell volume of above 50% and complicate the antiplatelet decision. So here we got a very clear cut and a defined way how to when to restart the therapy. So about 43% cardiologists considered platelet count below 100 to be categorized as HBR patient, and regarding restarting the antiplatelet therapy post illness, 40% restart immediately after the recovery, 33% after 1 week, and 26% continue during illness, showing varied practical approaches. Coming to restarting the therapy, restarting antiplatelet therapy after bleeding, most of the cardiologists preferred restarting antiplatelet therapy 2 to 4 weeks after last bleeding episode, balancing ischemic protection with safety. Similarly, around half of the respondents reported shortening DAPT or temporarily stopping antiplatelets during spontaneous or GI bleeding. Also, more than half of HCPs believe that age more than 70 years is prone to HBRs. So these are some of the summary findings which I have discussed. And here again, if we see the preference of the molecule, so around 47.7% HCPs for lowest bleeding rates, they will go for clopidogrel as a choice of molecule, followed by 27.7% for highest bleeding risk. They will avoid, they recognize prasugrel for the highest bleeding risk. So during the discussion, we also discussed about some of the barriers or the challenges when it comes to DAPT de-escalation, where cardiologists highlighted some of the barriers like limited access to bleeding risk tools, lack of region-specific guidelines. So when it comes to region-specific, like some states in India, they have more load of this tropical diseases, as compared to the other stage. So is there is a need of region specific guideline also. Variability in the HBR definition. So there is lot of heterogeneity which exists when it comes to defining HBR patients. So where a more clarity is required, and concerns about the ischemic protection after depth discontinuation. So all this reflect the need for a clearer protocol and India specific guidance to optimize bleeding and ischemic balance. So, from this brief summary from the survey, some of the key takeaway is that there is a clear awareness among Indian cardiologists about HBR, but uniformity in practice is still lacking. Clopidogrel remains the backbone of therapy in HBR patient post PCI, and also there is a strong call for a simplified Indian risk score where, and from this survey, we try to define a simplified risk score, which I have already shown, and guideline that considered regional realities, including comorbidities and tropical infections. The in-depth HPR study does give us a comprehensive snapshot of how bleeding risk is being understood and managed in Indian cath labs today. So, with this brief presentation, I would mention here that some of the interesting insight for the upcoming study that we already got a lot of detail about HBR patient, how to develop a simplified tool about HBR patient, what is the molecule which is most preferred. But then definitely in India, a lot of genetic variation that exist. So equivalent genetic testing is also not done. So some of the interesting insight we will come up with again, a new insight from extension of the in-depth study, that is in-depth insight. So before going ahead with this, I would end my presentation, and I would uh, go to the panelist over here, where from the study that we have, from the survey, the conclusions, some of the conclusions that we have received. So so we have seen that most respondent preferred clopidogrel as the antiplatelet agent. Do you think that this is driven just by the because of the cost, familiarity, or bleeding risk perception among Indian cardiologists, or because of a better safety and tolerability profile? So Jagdish sir, Oman sir, VT sir, anyone can take it.
No, the fact remains that in the last 5 years, we have gathered enough data which suggests that a month after more potent P2 white well inhibitor use following PCI, de-escalating to clopidogrel with aspirin or clopidogrel alone is a reasonable strategy. Now, this strategy is already 8 years old, but every year in every big international meeting, we are generating more and more data which suggests one thing: clopidogrel is safer than aspirin, clopidogrel is safer than ticagrelor, clopidogrel is safer than prasugrel. The other thing which is coming repeatedly, efficacy-wise, clopidogrel is better than aspirin. It has a little less efficacy with regard to ticagrelor and prasugrel for the first 1 month following PCI. The third thing which I have learned, of course, is that as you said, we have much more experience with clopidogrel, and there is no doubt that when it comes to bleeding part, we are reasonably happy with this bleeding profile. So the safety-wise, certainly it is better. Uh, more and more data are accumulating which suggests that in high bleeding risk individuals, you can actually either drop aspirin after 1 month to 3 months, depending upon how much is the bleeding risk. And also, you can de-escalate as quickly as 1 month. Lesser than 1 month, de-escalate means go on to clopidogrel rather than the ticagrelor or prasugrel. That kind of data is there, and that is why if you look at 2025 guidelines of the ACCHA guidelines which just came, they have actually given this both de-escalation and of course monotherapy in high bleeding risk individuals a class 2A indication. In individuals who are not high bleeding risk individuals and 3 to 6 months after going to monotherapy with clopidogrel is a class 2B indication. Clearly, more and more data are emerging showing that after a certain period, which could be anything from 1 to 6 months, probably 3 months, clopidogrel de-escalation using clopidogrel is a much better strategy. And even monotherapy with clopidogrel following PCI is a reasonably good strategy in high bleeding risk individuals. That is exactly what this survey also tells us. This survey is no different from what the world is collecting data. We have also collected the Panther meta-analysis, which has been updated again this year and was presented in last time in Barcelona ESC. Clearly, again showed that clopidogrel was a superior choice following DAPT discontinuation, and hence by corollary, you can actually, there was a 6 months to 18 months DAPT. So this clearly indicates that even after 6 months, you can go to monotherapy with clopidogrel and would have results better than aspirin.
Surely, sir. Thank you, sir, for such value addition. Coming to Oman, sir, sir, how the study will be helpful in Indian setup, and if some of the crux which Indian cardiologists would like to take up from the, especially the scale that we try to develop and simplify it from the existing risk scores that is there in the data.
Yeah, two things very clear. Dr. Mohan had made it very clear beautifully, so we will not repeat that. Only thing is the questions people ask and Indian doctors keep on asking is the duration of therapy. It say that uh, do we have any data for long-term clopidogrel instead of aspirin? And that was answered by host exam, which was old study published in Lancet, followed the extended therapy, and that is what 5.8 years or 6 years of follow-up. And versus aspirin, it was quite superior, 26% reduction, relative risk reduction, primary endpoint, and about 26% reduction bleeding. So that is the important message. We all think that aspirin is innocuous and it does not bleed. But I would like to draw the attention of the audience to a study called Averroes. It is not versus clopidogrel, aspirin versus novel anticoagulant or apixaban. It had as much bleeding as that of apixaban or anticoagulant. That is not low. So aspirin also bleeds, and now Indian doctors are realizing that. And another important thing which I thought was important from the study point of view is that the risk assessment and frailty came quite high in the list. And I was very Dr. Mohan always talks about frailty, and that is very very important, which we often forget. It's not necessarily the age. A 90-year-old person may not be frail, but a 60-year-old person can be frail, and that was given very high importance. That is something which is very very uh, very heartening. And other, the need for simplification of risk scores is very important. This is an attempt towards that. And the even body weight, age, or given high importance, but more than 80% gave very high importance to conditions like frailty, active bleeding, chronic bleeding dialysis, etc. So this is a good attempt. And clopidogrel we have been using. It's not only the familiarity with clopidogrel, and off late, no, it is not off late. There have always been some noise about ticagrelor, and which was exacerbated the early this year. And so that is where it stands. So I agree with the consensus that ticagrelor and prasugrel are for very niche, specific groups, and routine patients, clopidogrel, and high bleeding risk patients, that tailoring to monotherapy from in post ACS, maybe 1 month to 3 months, depending on the bleeding and ischemic risk. These are my comments.
Surely, sir. Thank you for adding those valuable comments and feedback on the survey. Coming to Shah, sir. So, one of the important findings that we have achieved is the most common bleeding that was observed is GI bleeding post PCI. And are there any India specific factor because of which it is experienced, sir? So, is it because of the NSAIDs use or maybe the dietary habit or easy access to the PPIs? So what could be the contributing factors towards this trend, sir?
Well, according to me, first of all, Indians overall have more GI problems than the Westerners. Maybe our diet, our spicy food. If you go to Europe, I mean, I've stayed 2 years in Germany, they hardly have any spicy food. Even our normal food, if they take, which I used to prepare, they used to feel so hot and spicy and all that. So I think overall, maybe our diet is one of the main reasons with our so-called curry masala or whatever you might say, which are very popular as far as taste is considered, but bad for the GI. And therefore, overall, we are. Then, of course, the other factors are there. And the other factor I would say is lot of misuse of these anti-inflammatory drugs. See, you go to a GP with sinusitis or URTI, LRTI, any fever, they don't give plain paracetamol. They give a paracetamol combination with a aceclofenac or something like that, so that both in injectable forms, in the IV form also. There is a very popular preparation, and I see most of the time they give that also. So I don't know. I mean, there could be other factors, but these are the factors which I feel in practice what I get. But having said that, and now Dr. Oman and Dr. Mohan already said about the preference of clopidogrel over aspirin as a monotherapy on long-term basis. And we have also emphasized that fact, and people are also preferring that. The only people who don't prefer clopidogrel as a monotherapy are the surgeons. You ask a surgeon, he'll say, stop clopidogrel. Give me aspirin, I am ready to operate on aspirin. Something like that. So I don't know whether we have mentioned this in our paper or not, that maybe when it comes to going for an operation, we might have to shift the patient from clopidogrel to aspirin, if at all one antiplatelet agent is allowed, if at all. If they want totally to stop is a different theory. Then there is one more thing which I am not sure whether we mentioned, we had discussed during our discussion, is that when all this antiplatelet therapy started, in ACS, CCS, other conditions and all that, post PCI, the variability in the stent platform and the polymer and the drug was too much. Now that factor has gone out. With all the second, third, fourth generation stents coming in, we now have a uniformity. So the development in the stent has come to a stage where we now are getting all these studies with shorter dual antiplatelet agents, or we are trying this out because now we know that the common factor is the stent platform now. Almost all the stents, minor variations are there in stent thickness and something like that, but the outcomes are almost plateaued now in terms of stent thrombosis and so on. So therefore now we are redoing all those studies which we did earlier, which like say Tika and Prasu came in ACS and we did that. But now we have studies even with clopidogrel that post 1 month, as Dr. Mohan was saying, or post 3 months in an ACS and post 1 month in a CCS. You can shift the patient to aspirin clopidogrel and then later on maybe even to a single antiplatelet agent like clopidogrel. So I think that we have good development. And the other thing which our paper does mention, unlike any other paper in the Western world, is the presence of tropical disease. Okay, very important, especially now in this season, post rainy season. So much of, even to get a cardiac ICU bed is difficult because they say beds are full. Why? Because all these fevers, low platelet counts, and multi-organ failures and ventilators, ARDS, and so on, it's all full with that. There the point comes, and then some of the patients are on these drugs and they are referred to us as to what to do now. How much to wait, how far to wait. So I think there comes the importance of our experience in telling that yes, at 1 lakh you still continue. When it reaches 50, 60,000, maybe you should stop it, a potent antiplatelet agent, and wait. Because see, the problem is all these agents have a window of 3 to 5 days of their efficacy. So in advance, you have to think that if your platelet count is falling, how rapidly, that your stopping of the drug should match that. Otherwise, it should not happen that the effect continues when the platelet count you stopped is 50,000 and then you come down to 5-10,000 or a bleeding episode. So I think we have done that very nicely. We have mentioned, and could be that we can be still more specific and say that start be watchful when you are around 1 lakh, and then maybe around give a margin for the drug which you are using, because Tika has a short window, I mean short half-life. Clopidogrel, prasugrel has more half-life, and therefore we should be able to uh, titrate or stop the drug at the best opportune time. Then the last thing I want to say or add in this is 1 second, HBR 3. Okay. I have a given situation to ask to Dr. Mohan and Dr. Abraham, which I am not sure whether we discussed this in the previous meetings, but recently I had and I have such few patients. Now, there are patients who are low platelet count chronically. Chronically, they are with low platelet count of 60, 70,000 or so. Various, the commonest reasons I see here, one of them is liver cirrhosis or something like that, where the bone marrow is not manufacturing. You refer to a hematologist and they'll say this is going to remain. You take care what you want to give. And then the other, of course, is post-viral infections. Some of them, the bone marrow is suppressed and are not producing that much of platelets, or maybe idiopathic, which they have developed. So you come across these patients who are on a single antiplatelet agent, maybe aspirin or clopidogrel, and they are out of the window period of acute coronary syndrome. In such patients, I have taken the analogy of patients post PCI with atrial fibrillation, where aspirin, clopidogrel, or Tika is stopped, and you switch over to only NOAC in the full dose. whether it is 5 milligram BID of apixaban or 20 milligram OD of rivaroxaban. Because in a patient of AFib post PCI, especially in ACS, where you are giving this dual agent, because now triple drug we have stopped after 7 days or 1 month, we are only giving dual agent, and that also one stops after 6 months, is also an option that after 6 months you can stop the antiplatelet agent totally and only give a single NOAC. The advantage with this NOAC is that the platelet count doesn't come down as against an antithrombotic agent like aspirin, clopidogrel, and so on. So that is the advantage, and I have found that the platelet count doesn't play mischief, and the patient is also comfortable. We are not giving a drug which can give rise to low platelet count, because every time they have to follow up with that platelet count, whether the drug is giving them a low platelet count. So in those patients, even in sinus rhythm, post PCI, 6 months or 1 year with a single agent and a single LOAC in the full dosage. So I think this is an exception, but yes, there are such instances. If Dr. Mohan or Dr. Abraham can throw light, or if there are some references like this, maybe we can mention that, or we should be able to highlight that. So rest, I think
Sure.
basically we divide our strategy into ACS, CCS, then which drug, how many and what, when to convert DAPT to SAPT with HBR and other factors. The conditions of HBR we have already mentioned previously. So I think and now again there is a new dynamism which is added to all this. And again, so I think this aspirin, clopidogrel, or antiplatelet trials and studies are still going to be further down the road. The dynamism will change. How will it change? When will it change? I'll give you example. Dr. Mohan, Dr. Abraham will also agree with this. So we have now lot of propaganda or marketing, as you might say, or lot of noise being created with use of drug coated balloons instead of a stent. Especially when you are going to put the first stent, think twice. Young patient, 35, 30, MI, or otherwise whether this patient can be let off with a drug coated balloon so that you don't put any metal, and therefore I'm not in an HBR condition. I'm not saying because of HBR, but electively. So that the antiplatelet regimen is less long-term, patient can benefit if he wants to stop for some reason or the other in between, which is going to happen if he's in his 30s and 40s, if he has 3-4 decades down the line. So now this, what is the optimum period post DCB for a dual antiplatelet and an antiplatelet to be given, single antiplatelet to SAPT and DAPT in an ACS and a CCS condition? That dynamics will be studies on that, and maybe again all this discussion might come along. Then the other situation nowadays, I mean, of course, that was already there with the BRS stents being available. And now still the noise is not as great as the first generation BRS had created. But yes, it is also slowly growing the concept that maybe after 3-4 years down the line, the single antiplatelet agent would be sufficient lifelong. And if at all there is some discontinuation required, then it can be done. And in that situation, what could be the best choice? So I think a lot of variability still remains, but we will have sessions like this every year then.
Surely, sir. Thank you, sir, for throwing light on many of the aspects from the trial. So we have couple of questions. Mohan sir, if you allow, then we can take the
Yeah, please
question,
go
sir.
ahead. Please go
Yes,
ahead.
yes, sir. So first question is again with clopidogrel emerging as the most preferred SAPT option post DEPT. How do we balance its lower bleeding risk with potential interpatient variability due to genetic resistance in Indian patient? This question is from Dr. Rao. So I think, sir, Dr. Rao wanted to understand that when it comes to de-escalation from DAPT without formal bleeding risk course with us and also platelet function testing, then how to go ahead with the decision making.
So the first, let us come to one thing, that the so-called clopidogrel resistance is a lab phenomenon rather than a clinical phenomenon. The host exam and stop depth and smart choice 3 studies, which have clearly shown superiority of clopidogrel over aspirin alone, or stopping aspirin within a month, as in stop depth 1, stop depth 2, and also in ACS, and in a population which is Korean, and clearly we know that in Korean population, clopidogrel resistance by lab methods is up to 30%. We have similar kind of clopidogrel resistance depending upon which method you use, whether you use verify method or platelet aggregometry method or anything else. But the clopidogrel resistance is not of clinical relevance. It is of genetic and bench-side relevance by and large. Why we have it? We have a study available called Gravitas, which had to be temporarily shut off because of futility, which Deepak Bhatt did, which showed that even people who after DAPT had platelet reactive units above 208 and below 208, the results, long-term results, which means intermediate results with regard to stent thrombosis and ischemic events, were similar. We believe in the guidelines, and guidelines do not suggest routine checking of platelet functions when the patients are on clopidogrel. Clearly, this is a non-issue. That is the first thing we have to understand, that clopidogrel resistance is a non-issue, and so-called inter-individual variability is there, but is a lab phenomenon. So long as you get, even if you get actually platelets which are, let us say, we are able to inhibit the platelets to the tune of 50% in the long-term basis, which clopidogrel quite effectively does, you achieve the target. It is in acute phase that you want 80% platelet inhibition of platelet aggregation, about 80% or 90%. But in chronic situation, after a month or 2 months or 3 months, a 50% platelet aggregation inhibition is good enough. And clopidogrel, regardless of how much clopidogrel resistance there, will do the good job about that. So we are convinced about that. The point which repeatedly comes actually in mind is, if aspirin and clopidogrel are equal, clopidogrel is cheaper, why not? Aspirin is cheaper, why not I continue with aspirin? Oh, now that the 5 years data of host exam, as Dr. Abraham Oman was saying, are available in Lancet, clearly bleeding risk is 30% less and ischemic risk is 25% less with clopidogrel compared to continuing aspirin. We believe that the matter is getting settled. The same kind of data actually we have from Smart Choice 3, but Smart Choice 3 basically is a trial where in actually clopidogrel monotherapy has been tried after 3 months and found to be non-inferior to a DAPT, but with less bleeding. So clearly we know that adding aspirin after 3 months probably is of not great use, although bleeding incidence is twice at least. My point actually would be that time has come reassess the whole thing. Following DCB, I think clopidogrel would be good enough drug-coated balloon. I completely agree with the VT, Dr. VT Shah. Number two, chronic coronary syndrome. Probably you don't need actually a long-term DAPT. We can further cut it down and change to clopidogrel. And a third important thing is, with the newer platforms, as he rightly said, more data are emerging, and some of the like in this ESC we had a data suggesting that in ACS patients following bypass surgery, aspirin is as good as giving dual antiplatelet therapy with ticagrelor,
Yeah.
clearly indicating there are situations where you don't need too much of platelet anti-aggregation, and CABG is one such situation, although guidelines still give it a class 1A indication. So new data are emerging, as rightly being said. We had a great study presented from Spain in this ESC saying that after a month you can drop aspirin following uncomplicated acute myocardial infarction PCI and continue only with clopidogrel. Things are pretty much all right. So we're collecting more and more data.
Surely, sir. Thank you for
If
taking
I
us
may
through.
just interject one
Yes, yes, sir.
point, I
Yes.
totally echo Dr. Mohan's words. The key thing is routine measurements. But sometimes, because now the interventions have become so common, but few situations where I would not call routine or I will check the CYP2C19 genetic testing is one left main stenting, bifurcation left main or LAD diagonal large area and trouble bifurcation stenting. ISR again stent over stent, and these are some situations and only remaining functioning vessel. So these situations I would be careful, and I will. My personal practice is I would do a genetic polymorph some CYP2C19 mutation test and then go ahead. That is how I do it. Secondly, regarding Dr. Shah's very intelligent point that why don't they give anticoagulants alone? We don't have data for that. So, but I'm not particularly worried if somebody is like some certain areas of our country platelet counts are genetically low. First thing I would do is I will ask the pathologist whether they are clump platelets or giant platelets. If both of them are there, I do not worry about any value less than 50,000. But
Yeah,
if
I would
the
agree with you. I would
yeah,
agree with you.
and cirrhosis of portal hypertension is one situation where I think Dr. Mohan was keeping on in a previous meeting. That is one situation. To me, that is a very high risk situation where I would be very, very careful. But if the values just come, say, 75,000, I will keep checking once a month and the value is near normal, or I'm sorry, remaining stable, I would not worry much. And thirdly, the if you have malaria or any viral illness, if the platelet count is on a downward trend, I will be careful. I'll repeat it very often. And if it's less than 50,000 without bleed, I will cautiously continue single antiplatelet. My criteria for stopping may be any active bleed or any value less than 15,000. It's similar to the cancer, the DVT prophylaxis, something like that. I want to hear Dr. Mohan's and Dr. Shah's opinion about that.
So one of the things I learned actually doing angioplasty of patient with ITP, idiopathic thrombocytopenic purpura, that in case they don't bleed, I continue to give clopidogrel alone even up to 20,000 platelets. And since we have now reasonable experience in last 25 years of treating ITP with coronary artery disease, they have lower platelets, but platelets are not that dysfunctional as happens in acute infections. I have recently actually got a reasonably good number of patients with CLL who have thrombocytopenia. Now, this is interesting that, and of course, one CML patient, but CLL patient, they tolerate clopidogrel alone pretty well actually on a long-term basis. I have been hesitant to give them aspirin again largely because of this host exam data, and I don't see bleeding. In fact, my guess is that platelets are not that much cause of worry as much is the bleeding tendency. Sometimes platelets are 1,50,000 and patients show subcutaneous bleed. That is the time when I stop one of the drugs and usually aspirin, and actually then even and continue with clopidogrel. If patient still bleeds, I will judge the nuisance value of that and how frequently are the ecchymosis occurring. If the ecchymosis is occurring once in 2 3 weeks and it is a small area, I probably will continue clopidogrel. And it is a fact that most of these people actually they stop having ecchymosis after some time. We all keep blaming only the antiplatelet drugs for subcutaneous bleed, but there is an issue of capillary fragility and other things which we also have to keep in mind.
Surely, sir. Uh, so I think one webinar cannot fulfill the all the findings that we have received from the trial, because there are so many findings yet to reveal. And we will just go to the last question, looking into the time. So it is about do you see a role for temporary switching to anticoagulant-free strategies in patient with severe thrombocytopenia due to tropical illness?
That's what I was asking. That's what I was saying. That
Yes,
when you have such thrombocytopenia and you have to stop this, we are extrapolating the data from the atrial fibrillation trials where only a single anticoagulant is given and no antiplatelet agent is given. In those trials, it was after 6 months to 1 year, majority 1 year, I believe. And but now, as I said, we can extrapolate, especially in chronic coronary syndrome or chronic stable angina stented patients, to single anticoagulant uh, and omit the antithrombotic agent in these thrombocytopenia patients.
My
Because what happens is the problem is that the scare which is created by the physician in the patient's relative's mind, अरे प्लेटलेट इतना लो हो गया बंद करने को बोलो उनको प्लेटलेट इतना लो हो गया बंद करने को बोलो and sometimes because of that pressure we have to change the drug as early as possible. So that is
the
what.
hypothesis looks very attractive. My only concern is platelets are involved in generation of factor 12A because they provide the template. The platelet surface provides the template by virtue factor 12 gets converted to 12A. So in intrinsic pathway, platelets are important part. Your lower platelets, the intrinsic pathway actually would be less effective and chances of bleeding would be more because now you are already having much less factor 10A. And on top of it, when you give drugs like apixapel, you may completely knock off the factor 10A from the circulation. And that could promote some degree of bleeding. That is my theoretical concern. We already know that people who have actually low platelets have less factor 10A. So I'm just, presuming that there is still a chance of little bleeding when we give only DOACs in people who are thrombocytopenic. But I am going to read this matter in much greater detail.
No, please read, and
Yeah,
I'll tell you
yeah,
that the arm of only apixaban was versus apixaban plus aspirin.
yeah.
It was not against placebo. So for you, it should be very easy to find out whether there was high bleeding risk for even these people. From what I gathered, I saw that there was no concern of high bleeding risk in those patients of apixaban versus apixaban plus aspirin in the apixaban arm.
I'm not.
But theoretically, what you say, I mean, but in practice, what happens? I think Dr. Baishali can go through all that and find out whether, because this is, see, it is quite uncommon for the Westerners to think of all this. But for us, I think right now actually had so many such opportunities in this so-called tropical storm which is coming post rainy season.
Surely, sir. So definitely a lot of insights we have received with this HBR survey, HBR Insight, and definitely we will come up with more such findings in detail with the in-depth insight study. So we are still gathering the insight from the cardiologist. So again, I would like to thank the experts for your valuable time and sharing such wonderful insight and guiding us throughout this journey of developing this